Good day, my dear students. I welcome you to R.A.T.S. This is our logo over here. What do you mean by the word R.A.T.S? Racing Against Time for Students. I have chosen this for pathology. Let us see what we are going to cover. The topic for the day or other topics shall be pathological calcification and gangrene. The importance of it and where to emphasize upon shall be dealt with in this particular class. So this is our class again, and the questions can come in the form of short notes, viva voce, MCQs, in pathology as well as surgery. In surgery, actually, this can be a routine case for us. And sometimes the calcification can be an enigma in diagnosis. Subheadings. I always put a list of subheadings and we are supposed to follow them. Think of the subheadings. The subheadings will take you to the answer. These were the words of my professor, Sir Augustine Paul from dermatology. There are basically two types of calcification. One is physiological. All of us are getting our bones formed. They undergo what is called as mineralization. They become stronger, and so do the teeth. So this is called as physiological calcification. But what we are worried about is pathological calcification. What do I mean by the word pathological calcification? There are basically two types, one of which is dystrophic calcification. Dystrophic. Remember the letter D. D is for dead and degenerating tissue. Dead and degenerating tissue. The normal characters can be the serum calcium is normal, 9 to 11 mg/%. Serum phosphorus is also normal. So this is an important parameter to differentiate it from another type of calcification. And where does it occur? This is an entire list of degenerating or dead tissues where we can find dystrophic calcification. I shall read it for you, so shall you. Tuberculous lymph node, any old infarct, arterial thrombus, dead parasite, atheromatous plaque, Monckeberg sclerosis, Samama bodies, senile cardiac valves, humoral calcinosis. And take care, my dear students, any of these can be asked as a question, not to fail us, but then to give us additional marks. So please concentrate on that extra mark which you are always capable of. This is a Monckeberg sclerosis. Frankly speaking, this is a slide that I used to keep for my undergraduates. And we routinely see it in the reporting as well. This is an artery and in which I am finding bluish purple amorphous material that is getting deposited in the media. So that is why some books call them as medial sclerosis or Monckeberg sclerosis after the person who designed it or identified it. Here, okay, the arteries are usually circular, veins are more collapsible, that we understand. But what has happened to this particular blood vessel? It is taking an ovoid shape, which is not very regular. It has got a slight bend here and there. And the calcifications are dark purple accumulations in the media of the blood vessel. And my professor used to call it a swan neck-like deformity or appearance. Swan neck-like deformity can be get in other sites also, such as a digit in a case of rheumatoid arthritis. In fact, that is more classical, a radiological picture, a diagnosis. But this we use it at the microscopic level in pathology. This is an examination slide for you people. I would advise you people to kindly go to game. There is no fame without game. Find out what game is. Now students, what is the heading of this particular slide? Stains for calcium. In pathology and histology, we have got only two stains, hematoxylin and eosin. The pink color and the blue or the purple color. That's all. But how do you identify all the tissues, all the lesions with these two colors? Sometimes it becomes impossible. Therefore, we will be using what is called as special stains for certain substances. These may be asked as questions, as MCQs, and if you do answer as part of the theory, you get an additional mark for it. Also in the Viva, there is a chance that you might impress the examiner. So this is a HNE where the calcium is basophilic, B for blue. The special stain for calcium can be Von-Cosa. Von-Cosa, it gives a black color. And another stain is alizarin red. So look at this one. That area of calcification has taken up a red color. So this is alizarin red. These two stains we shall remember. Von-Cosa and alizarin red. And look at the histological picture. It is from another lesion. I find, can you people describe it for me? I'm finding it a little difficult. So, yes, you are correct. So there is a bluish, amorphous, acellular, irregular deposit that is seen. There is no nucleus, no cytoplasm, no cell membrane. It is amorphous. That is how exactly calcification will appear in the tissue that is stained with HNE. That is basophilic. You agree with me? Basophilic means blue in color. We have read out a panel of examples. Dead and degenerating tissue. Let us concentrate on this one first. It is a specimen for us and it can be kept as a spotter also. So it is a lymph node. There are irregular areas of necrosis and some of these spots are becoming hardened because of calcification. What is the definition of dystrophic calcification? It occurs in the dead and the degenerating tissues. So this is a tuberculous lymph node that is getting calcified. Sometimes what will happen, here you are seeing a radiological picture. Normally when you take an X-ray, these spots are all not seen. But in this X-ray they are seen because the tuberculous focus has got calcified. So this we call as the Ghon's focus. Ghon's focus is below the pleura, subpleural in location. Then via the lymphatics, it comes to the hilar lymph nodes. These together, the focus, lymphatics, and the node constitute what is called the Ghon's complex or the primary complex. We will see that at a later date. But the importance is they are all calcified. And this is an autopsy specimen, obviously. And when you see the node, rather the Ghon's focus, it has undergone a calcification. This is the lung otherwise with a black anthracotic pigmentation. How do you describe? For any lesion, you people should describe the gross appearance and the microscopic appearance. Gross appearance, very simple. Use the keywords alone. Is it regular? Irregular. It will be firm to hard. Even when you touch it, you people will be knowing. Hard is a word, in fact, we should use with great caution. Even in your clinical surgery, there are only two substances which are hard. One will be the tooth, the other is bone. Even if another lesion is firm, you cannot call it hard. But in this case, it has become solidified and hardened because of calcium. Firm to hard in consistency. Gritty like a chalk. It has got that kind of a consistency, but not easy to break. Chalky white or yellowish white. Here also I am finding a blend of this yellow and white. It can be solitary, it can be multiple. Here it is multiple, involving all the valve leaflets. And it must be decalcified. If you want to cut the section and then study it under the microscope, you have to remove the calcium, which is called decalcification. Repetition is the mother of knowledge. What is the microscopic appearance? I have already told you in a previous slide. It is basophilic, blue, amorphous, irregular, acellular, with no inflammation. This will be the very simple description. In fact, it will appear a little complex. Just memorize what I am saying. That will be the gross and the microscopy of pathological calcification. Look at this one. This is a large, hard nodule that the surgeon or the dermatologist is feeling in the gluteal region. They feel that it is a tumor because it is so large, it is hard, it is gritty. There are some bone tumors also, cartilaginous tumors. So they will have a suspicion. They excise the entire lesion and send it to pathology. And we on cutting, we will be having to cut it with a saw because it is difficult for us also. And we find irregular, yellowish white, chalky areas of deposits, which, as I mentioned earlier, they are under the H&E stain, amorphous, acellular, basophilic, irregular, with no conspicuous inflammation. So this is easy. Now, what are you seeing in this one? There are a few radio-opaque structures in the body. One is a bone, other is a tooth. But here we are seeing another line. There is another line that is seen, which is radio-opaque. This is a calcified dead parasite, a guinea worm. So there is a condition called as larva migrants, etc., which you people will be reading in microbiology, parasitology. And this parasite is dead, maybe with the treatment or without the treatment. So this is called a calcified dead worm, a guinea worm. Again, the aortic valve. Usually in senile aortic valve, there can be some changes. Senile means old age. So this is a normal one. I have kept this for comparison. Normally, I find that the valve leaflets, these are the leaflets and these are the margins. When they close, they oppose very snugly. They do not allow blood to either come in or go backwards. Secondly, the leaflet is somewhat glistening and translucent. I can't say transparent, but translucent. It allows light to pass through. But look at what has happened over here. It has become opaque, irregular, thickened, and there is a damage to the structure of the valve leaflet also. It is not able to close completely. The patient can go in for an incompetence of the valve. This is a totally different condition. It is called a Samoma body. Samoma body is again an area of calcification. Here I find, can you describe it any better? Yes, it is concentric. There are concentric whorls of calcium. It will be mixed with iron also. You find that are deposited in a tumor. And they can occur in some tumors like meningioma or papillary carcinoma of the thyroid or serous carcinoma of the ovary. These are some examples. So this is called a Samoma body. P is silent. Next friend of ours is metastatic calcification. Metastatic calcification, there is a specification. It occurs in organs or tissue with a constant exchange of material across them. This is one way to remember. Organs are tissues which are having constant exchange of material across them. So what are they? The GIT, obviously, lungs, kidney, blood vessels. What is common to all of this? There is a lumen and then there is an exchange of material across the wall. Secondly, there is hypercalcemia. So calcium is increased. This can be because of increased absorption or it can be because of mobilization from the bone. From the bone, the calcium is being liberated. Therefore, the serum calcium is increased. That is why it is called anemia. Anemia means no blood. Hypercalcemia means increased calcium. And what are all the causes for this one? Hyperthyroidism, hyperparathyroidism, milk alkali syndrome, vitamin D intoxication, multiple myeloma, chronic renal failure, sarcoidosis. These are some of the examples. The entire panel is given in your Robbins or in my book, The Tips. So it will be easy for you people to recollect. Please memorize this one. What are the organs? What happens to the serum calcium? And what are the list of causes? Pathogenesis. This is common to both dystrophic calcification and metastatic calcification. So the deposits are amorphous or crystalline form. There are two stages. One is called as initiation, other is called propagation. The calcium and phosphate accumulate inside the degenerating cells in the mitochondria. This is called an influx of calcium. I've explained it in my first class on cell injury. The calcium, the sodium, they come into the cell and they accumulate in the mitochondrial organelles because of influx. Propagation. Once there is a nidus or nest of material, more and more material keep on getting accumulated, and that is called propagation. So these are the two stages. It can be in a mineral form with or amorphous form, or it can be in crystalline form, hydroxyapatite crystals. That is what we used to say. So this is the pathogenesis. It is common to dystrophic and metastatic. Gross is common to dystrophic and metastatic. Microscopy is also common. Basically, there are two types of growth. Any substance can grow by accretion. More and more particles get deposited. Coral reef is one good example. And you get a huge structure. Or by intussusception. Your body, how are you created? It was by means of a zygote, a morula, and today you are having millions of cells in your body. So it is by one becoming another, or multiplication. Growth by intussusception. The complications of calcification, or rather metastatic calcification, can be vascular narrowing, as in the case of an athyroma. Valvular stenosis, I have shown you. There can be a renal failure. Tumoral calcinosis can be a surgical misdiagnosis. Tumoral calcinosis. So these can be some of the importance which you people can mention. And the significance are sarcoma bodies. They are supposed to be indicative of tumors, which I had mentioned earlier. Meningioma, medullary carcinoma, or rather the papillary carcinoma of the thyroid, and then the serous carcinoma of the ovary. So a line from Robbins, it is better to understand a little than to misunderstand a lot. Dear students, the other topic for the day is gangrene. So the importance is given in the enclosure. I shall not be repeating it. But then it can be a very important source of viva questions. And the questions can go in any direction. Let us see what the Pandora's box has got in it. Gangrene. The definition. It is death en masse. En masse means a lot, a huge mass together, all together. Death en masse with superadded putrefaction. Definitions are definitions, no one words please. Death en masse of a tissue with superadded putrefaction. Look at this one. So there is a blackish discoloration. I'm able to see some folds and bends. Let us appreciate it before we go to the next slide. There is a definite line of demarcation. This particular tissue is pink and viable. This toe is also becoming gangrenous. But these are definite gangrene. So what the surgeon will have to do is, with a definite line of demarcation, he has to amputate. And this again. So you find that there is one, and the problem with the gangrene is, if it is not treated initially, it will be spreading along a plane. There are two types of gangrene. One is called the dry gangrene, the other is the wet gangrene. Dry gangrene, what can be the causes? TAO, thromboangiitis obliterans, otherwise called as Burgess disease. Raynaud's disease, ergot poisoning, frostbite. When you are caught in ice, you find that the digits can undergo a gangrene. Anum, this is a condition where there is a constriction developing at the root of the digit. It becomes deeper and deeper, and ultimately the digit falls off. This is called auto-amputation. Anum is an example. Any major trauma, electrical shock itself can lead to a gangrene. So these are some of the examples. Thromboangiitis obliterans or Burgess disease, Raynaud's disease, frostbite, ergot poisoning, anum, major trauma, such as an electrical shock. I would like you people to kindly appreciate it. So these are the digits that have undergone a gangrene. Only thing is, there is a definite line. I can draw a line in between the diseased portion and the viable portion. And as in the previous slide, there are some differences which I shall be explaining in a tabular form. This is another type of gangrene, gas gangrene. Obviously, you people can see the air bubbles or the gas that has been produced in the subcutaneous plane. And all of these are showing that blackish discoloration. So this is a gangrene. Yes, students, I would like you people to explain. Always the advantage of pathology, radiology, and dermatology is that we can see. And we have to describe what we see. This is a loop of the intestine. This is the mesentery that is supporting the intestine. And these can be the blood vessels and their branches. I hope you are able to understand. Intestine, mesentery, blood vessels, branches. What happens sometimes is it gets twisted on itself using this blood vessel and the mesentery as an axis. What happens when it gets twisted? What will be compressed earlier? Will it be the artery or the vein? The veins get compressed. As I asked you, what will get compressed? Look at this one. This is a beautiful sketch of a volvulus of the intestine. Or sometimes you find that there can be a strangulated hernia. This is a hernial sac and it is getting tightened. The intestine is getting gangrenous. In this particular one, I'm finding that the loop of the intestine is twisting with the mesentery as an axis. At this particular point or this point, I find that the veins will get compressed more, as a result of which the blood will not be able to leave the region. You should be able to explain what I'm saying word by word. The blood will not be able to leave the region. So it undergoes deoxygenation. All the oxygen is utilized, and finally there is no oxygen. It becomes necrotic. There is death en masse. So this is simple for us to understand. Using the mesentery, it twists, turns black in color due to deoxygenation. Same process over here in a strangulation of a hernia. This is all called wet gangrene. Now we have got two types of gangrene, the dry gangrene and the wet gangrene. If you want to know anything further, go to game. Always I tell you students, there is no fame without gain. What are the differences between dry and wet gangrene? This question has been asked 700 times in pathology. So these are the characters, please understand. Site. The dry gangrene is more common in the extremities. Wet gangrene is more common in the bowel. In the extremity, it is a diabetic foot that will go in for a wet gangrene. The causes are, we have mentioned the causes earlier, TAO, Raynaud's disease or ergot poisoning. Wet gangrene can occur in diabetes mellitus, a strangulated hernia, torsion of the testis or volvulus. The mechanism is, here there is an arterial occlusion, whereas here there is a venous occlusion. Color, both of them are black. In a wet gangrene, it will be more grayish black, whereas here it is black and it is mummified, shriveled, dry. That is what I showed you in one of the first slides. There is a fold on the skin. That is what we call as shriveled. When you dry a wet cloth, what happens? There are a lot of folds appearing. That is shriveling. Mummified means it is as protected as an Egyptian mummy. Whereas in a case of a wet gangrene, it is edematous, it is swollen, it is soft, moist and dark. It will obviously be foul smelling, whereas it is minimal over here. The putrefaction is minimal because of the decreased blood supply. Here it is marked due to stagnation. Line of demarcation. It is clear in a case of dry gangrene, not so clear in wet gangrene. Therefore, it is a challenge to the surgeon. They will be leaving a little bit of normal tissue and then doing the surgery. Foul smell is minimal, it is profuse. Prognosis, it is better due to limited sepsis, that too in the extremities, whereas here it is bad due to profound toxemia and extensive necrosis. It is an amputated specimen of the leg. So the leg is over here, the foot is over here. There is a blackish discoloration seen throughout, almost up to the margin. But there has been a little bit of tissue that has been left behind, and when studied, it was found to be viable, thanks to the surgeon. And had he not done it, already you find that there is an ulcer that has developed, it has healed, and it has been spreading. The entire limb would have become gangrenous. It classically happens in a case of diabetes. This is one condition where you will be having a wet gangrene in the extremity. This is a beautiful picture of the same. I would like you people to draw it in your records. This is yet another condition, almost similar to the strangulation. There is a condition called as torsion. Look at this testis. You find that there is a strand over here and a twist on itself, using that as an axis, the cord. And what happens is the veins get compressed. The blood is not able to leave the region. It becomes deoxygenated, and therefore the area becomes black due to necrosis. And it becomes foul smelling due to the hydrogen sulfide produced by the organisms. An important point that I had forgotten to mention earlier. The foul smell is due to the hydrogen sulfide produced by the putrefying bacteria. Initially, they will try to unfurl it, but it is a risky one. Therefore, sometimes they will have to open up and do a corrective surgery. Testis is very important. They could not amputate it. But if it is going to be gangrenous, there is no other way but to resect it. This is a totally different condition. Here I find that the scrotal skin and even the adjacent skin, etc., they are all becoming gangrene, a real death en masse. And this particular condition is called as Fournier's gangrene. So far we had seen dry gangrene, wet gangrene, Fournier's gangrene, which is a variant of this one. And this is one other type called the gas gangrene. The source of it is over here. And look at this limb. It is a thigh wherein there are a lot of air bubbles or blebs that are seen. there is a blackish discoloration. It is filled with cystic fluid, and obviously the area is swollen, edematous. It is caused by an organism called as Clostridium perfringens. It is called as Clostridial myonecrosis, necrosis of the muscle. Clostridium perfringens, Clostridium welchii, etc. They are all the various organisms which can cause that. This is yet another example wherein there is a bleb, it is becoming edematous, swollen, and gangrenous. The speciality of it is it spreads along the plane. You have got different planes, subcutaneous plane, facial plane, etc. Along that, the infection spreads very rapidly. It is because of the various toxins, alpha and theta toxins or the beta toxins, which will be causing all the damage. It is foul smelling, necrotic. A crepitus can be seen. Sometimes when you palpate, there will be a crackling sound, which is called crepitus. But we are not supposed to do it because it will dismantle the polluted air and help it to spread. The treatment will be debridement. Open it and then expose it. After all, they are all anaerobic bacteria, and therefore you find oxygen itself is a poison for them. They will die. In addition to the antibiotics that you people give. So antibiotics alone are not sufficient. There has to be a surgical debridement, and if necessary, maybe we will have to do a resection. This will be the mode of treatment for it. Gas gangrene, they can ask you, and if you people do answer as part of the gangrene, you score an additional mark. Gracias.